Alright, hi everyone. Let us see this cornea, sclera, conjunctiva quiz. Alright, so I'm ready to give the test. Alright, so the first question is image question. This sign was shown and the following sign was seen 2 days after extracapsular cataract extraction where one of the sutures were exposed. So sutures can lead to this sign. This sign is upper palpebral conjunctiva showing papilla. Sometimes the papilla can be more than 1 millimeter, that is giant papilla. So this is giant papillary conjunctivitis. But what can be the condition associated here? Is the question is, of course the answer is, now if giant papillary conjunctivitis is the answer over here, if it is a mostly boy 5 to 15-year-old with itching, burning sensation in the eyes mostly in summer with this picture, then it is vernal keratoconjunctivitis. Follicles mostly goes in favor of infection, and this vernal keratoconjunctivitis when becomes a young adult, then it is atopic dermatitis associated atopic keratoconjunctivitis. Here it is cobblestone appearance, giant papillary conjunctivitis due to sutures, due to allergic reaction. Also it can be due to contact lens as well, mostly soft contact lens. Now, operation presented with the painful decrease in vision after wearing contact lens or the examination slit lamp. It was seen that most of the cornea was sloughed out and the posterior layers were protruding through the thin cornea. Posterior layers means Descemet's and dua were protruding through the thin cornea due to sloughed out cornea. This condition is known as descemetocele. Only the Descemet's and duas are protruding out through the abscess, through the thinned out cornea. That is protrusion of the Descemet's, because Descemet's was considered to be the strongest layer of the cornea. Now dua is the strongest, but still the name is descemetocele. Now this can lead to perforation if there is an increased sudden exertion of the eyes. So descemetocele can lead to perforation. Perforation can lead to plugging of the perforated side by iris, that is pseudocornea. And pseudocornea can lead to two different situations. One, if it is heals forming a adherent glaucoma. One, if the pressure increases, then it is an anterior staphyloma. Here the answer is descemetocele. Now, 24-year-old patient presented frequent change of glasses. The visual active was 612 with -2 diopter spherical with -4 diopter cylinder. Means there is astigmatism and slit lamp did not reveal any abnormality. The next step is patient with frequent change of glasses with astigmatism. Everything is normal in the eyes. You have to suspect keratoconus, and for keratoconus you have to do surface of the cornea, that is topography. That will include like pentacam test, orb scan test, thickness, curvature, surface 3 in 1. That is done for keratoconus. Now posterior staphyloma. Staphyloma means bulging of the outer fibrous layer lined by uvea tissue and bulging. Posterior staphyloma is associated with all except. It is seen in high myopias when the choroid is thin and sclera is bulging around the optic disc. That is, in high myopias have large optic disc. They can have peripapillary atrophy causing enlarged blind spot. But high myopia, high axial myopia has deep anterior chamber, not shallow anterior chamber. A very important question is false regarding the following sign. This is a dendritic ulcer shown in a cobalt blue filter with a fluorescein dye use. So this is, if you can see over here, this is your slit lamp. Now in the slit lamp, yeah, this is the slit lamp. In the slit lamp there is a knob known as cobalt filter. Now if I change, there is a knob known as cobalt filter over here. If I change the knob from here, you won't see over here, but there is a knob over here. If I change, it will come out as a blue light. I don't know if you can see the blue light over here, but there is a blue light coming over here. That is cobalt blue filter. That is a very important question of PG exam. That always when the cobalt blue filter is used, fluorescein dye is used. And this is the dendritic ulcer that is seen by herpes simplex 1. So orange color, fluorescein is an orange color dye. To see in the cornea, blue light comes from slit lamp. Diagnosis is not herpes zoster, it is herpes simplex, because there are some bulbs over here. Tapering ends are there in herpes zoster. That picture won't be asked. So this is dendritic ulcer. The ends are knobs, swollen, and there are virus present in the ends known as knobs or bulbs. And corneal sensation is reduced in viral keratitis because the virus can stay in the ganglion, trigeminal ganglion, which is the sensations of the cornea. Now, school teacher presented with redness in her eyes, which was recurrent and resolved by a drug. On examination, redness was more than phoresis, joint pains, proximal finger deformities, means arthritis, collagen vascular disorder was there. That is recurrent and resolving with drug, that is episcleritis, and the drug might be phenylephrine. So acute episcleritis is the answer over here. Now, why not anterivitis? Because nothing is, and more in phoresis. In anterivitis and scleritis, there is circumcorneal redness. In conjunctivitis is not the better answer because mostly episcleritis is idiopathic but can be related with collagen vascular disorders like rheumatoid arthritis. That's why episcleritis is the better answer over here, and the drug might be phenylephrine. Now, Fuchs dystrophy is a dystrophy of the cornea affecting the endothelium layer of the cornea, that is the most vital layer of the cornea. And endothelium maintains the transparency by sodium potassium ATPase pump. If there is endothelium cell loss, there can be corneal edema, and that corneal edema is not in the maximum in the evening; it is maximum in the morning, because already in our eyes the endothelium pump is not working at night, because at night aerobic converted to anaerobic glycolysis, because oxygen is not coming. Oxygen does not come when the eye is closed from the air. Aerobic convert to anaerobic. Anaerobic can block the sodium pump and cause edema. So already in the morning, in our eyes, in your eyes, my eyes, edema is maximum in the morning. In those conditions in which there is an endothelium problem like Fuchs dystrophy, that is maximum edema in the morning. Specular microscopy is for the investigation for the endothelium, that is abnormal in this. Advanced can have bulla in epithelium, yes. First step is endothelium cell loss, that is known as corneal catheta as well. Second step is stromal edema. Third is bulla in the epithelium. And yes, Descemet stripping endothelium keratoplasty can be done in advanced stages of Fuchs dystrophy. And the last question was 29-year-old patient with neurology was seen in neurology department for akinetic rigidity, jaundice. Basal ganglia, liver, eyes, rings are there, that is Wilson's disease. And in Wilson's disease, if it is not seen on slit lamp or torchlight, gonioscopy is done, because it is deposited in Descemet's membrane, the copper is deposited in Descemet membrane, and the first structure seen on gonioscopy is Schwalbe's line, and the termination of Descemet is known as Schwalbe's line. So before slit lamp, it is seen on gonioscopy device to see the cases, Fletcher's ring. That's the 8 questions. I hope you have done well. Best wishes.